I mean, come on, no one plans to get sick. And yet, here we are. My name is Matthew Zachary. I survived cancer, a stroke, and COVID-19, and I'm still here. I also survived our broken healthcare system, and I want to help you survive it too. So let's go make healthcare suck less together, because we're all out of patience. Hello, friends. Huge show today with Dr. Lisa Richardson, Division Director of Cancer Prevention at the CDC. The CDC! As the first guest I've ever had on the show with a BS in zoology, Lisa's the real deal. She's down to earth, she speaks person and science simultaneously, and she's been a 25-year first-hand witness to the staggering revolution and evolution of cancer care across these United States. In this rapid-fire, no stupid questions episode, Lisa and I talk about everything from simulated humans, plummeting screenings, mRNA, and telehealth, to 1990s-era patient activism, the rise of cancer survivorship, cancer and COVID, and the prospect of 2021 vaccine parties being the exact opposite of pox parties. Hilarity ensues today. Enjoy the show. Lisa Richardson, thank you so much for joining me here at Out of Patience. My listeners know that I tend to spiel and control people's LinkedIn profiles before I even get to know them. And I really can't help but start out by asking you, where does zoology fit into your backstory?
My backstory on zoology is that was the major I chose to prepare for medical school. That's the only reason I did it.
And how did that pan out?
Well, I got into medical school. Now I'm a doctor working at the CDC, so it panned out pretty well.
So help me understand and unpack a background, and not in pre-med, or does zoology count as pre-med, or learning about mammals and amphibians? Does that predispose you in a better sense to appreciate the medical profession?
I don't think it did, but it was a science major, and I had to take all the classes that would you'd need for medical school, and I thought it would be cool. So I really, to your question, I don't think I ever thought I would use it specifically, but I guess I would have if I hadn't gotten into medical school. So that's the backstory on that.
Did it encourage you to have any more pets than normal?
No, actually, it did not. I don't think I've had a pet since I was a little kid.
So it dissuaded you from having pets, says me.
Maybe a little bit.
Yes.
But no, I just, it was a major. It was interesting. I liked studying animals. And so that was the major I chose. And also I thought I had to choose a science major if I wanted to go to med school. So that's what I did.
Well, as the first zoology guest on my show, I welcome you again. Help me understand this is an open question I ask anyone in the medical profession. What drives people to go into medicine in the first place? Where is that dogma principle?
So for me, it was reading Elizabeth Blackwell's biography when I was in 5th grade. So I wanted to be a doctor since I was in the 5th grade in elementary school. And so pretty much from that point on, I was preparing myself to go to med school and to become a doctor. I think it's just really cool that you go out and you help other people. And that has a lot to do with why I chose medicine as well.
Wow. So you have been working in the government for a very long time. Mm-hmm. Was that right out of med school?
No, I graduated from med school and went to the University of Florida hospital to do my residency and fellowship. Then I went to Michigan and got my master's degree, and then I came to CDC. So that was in 1997. So done a lot of school too.
So your career is as old as my brain cancer.
Yeah. Yes, it is actually. Felt like it when I was getting there too, tell you the truth. The length of it, I mean, not the cancer part.
You know, I want to talk about how some of the issues we're going to discuss on this show are against this odd backdrop of how far we've come. That's kind of hard to see through the lens of the last 20 or 30 years in oncology. And if you think about the 90s, that was when cancer was whisper, boogeyman, death sentence, no support, pre-internet, very analog. And today it's obviously very different. And the issues we have, would you equate that to be nicer to have issues than just kind of dying? Or is it completely a different way to think about what is cancer control? what is population science?
So there's like two parts to your question. So the first part is you're absolutely right. When I trained in oncology and I finished in 1995, we were just starting to turn the corner on people. So when I was training, you got cancer, people thought it was a death sentence. But as we go along, like you just said, 20 years, more people are living longer. And it's been really hard for us to pivot away from the death part and just trying to keep people alive to helping them live better and longer and better quality of life afterwards. And so when you're in that, what do you call it, in the trenches mode, trying to, as you just said a few minutes ago, I want to live, so whatever it takes, that's pretty much how we're having to shift. And it's been difficult to shift towards something you live after you get rather than something you die from. And the second part, I think, is you asked about the medical system. So what we do at CDC, looking at population science, is what are the interventions we can do, or what are the things we can do to increase the health of the population, and that would be physical activity, eating right, not smoking. That's where you would see on a population level the impacts of those interventions. But remembering, as an oncologist, the tension for me is the population is what we're focused on, but also we can't forget that the individual makes up the population. And so that's where the tension comes for someone like myself. Let's find the cancers and treat it. Larger interventions in populations make the biggest change.
I can't help but think it'd be remiss of me to not mention the fact or remind our listeners that you were there in the trenches in the 90s when I would say the official patient revolution kicked off in the breast cancer universe.
Yep.
What was the response back then from the government reacting to American citizens who were just as fed up as the ACT UP AIDS activists?
Well, that's actually that's a very good question, because back in the 90s when I came to the CDC, the breast cancer advocacy group, as you just said, they were very active, very passionate. And a lot of the changes in the program that we have for uninsured women happened during my tenure at CDC and my first time around in the cancer control division, getting the program passed in the early 90s. Women have follow-up after abnormals, and then eventually treatment was covered by Medicaid. But I think it was because of a very passionate, targeted and focused advocacy effort from women with breast cancer.
My first experience with the CDC was when I took a volunteer role at Livestrong in 2004.
Yeah.
And they handed me this booklet called the National Action Plan for Cancer Survivorship.
Yep.
That was put together with the CDC and with Livestrong and a couple of other groups. And it blew me away that, hey, I'm just a layperson that knows nothing about advocacy. And I'm reading this book that can't imagine any other American would just willingly want to read. Because it's not like it's not like a nightstand kind of thing you want to pick up or whatever. Really heavy stuff. Mm-hmm. But let's discuss the gravity of that document.
Yeah, so that document was really the first chance to sort of lay out what cancer survivorship is, what needs to be done, and what the gaps and the needs were. Because when that was produced in 2004, even, it was a new field that people were just getting into. As well as the CDC and the other groups that participated. Right after that, the National Academies published the report on transition into survivorship. And so those two documents together has pretty much led or directed the field over the last couple of decades.
They really were the cryptexes of their time, setting the stage for here we are 16, 17 years later.
Right.
Again, it can't go understated that this was a time when, we can overuse the word revolution as much as we want, but this is the time where patients drove policy, they drove practice. And I think about something as simple as, and this is the throwback for the listeners, something called the Directors Consumer Liaison Group that was brought out with the National Cancer Institute, which brought advocates in to help shape these documents. A truly seminal moment. But again, to put in perspective here, talk to us about how there was this transition where it went from let's hope you don't die to let's hope you live well.
Right. So, like I said, it was and it still is one of those things, and it's even with patients who have cancer that, it's sort of it's a journey. And when you get to the end of the journey, then there's a transition. And, we're still struggling. I read something on one of the social media outlets that, when the lady got done with her treatment, she was like, now what? Right. And so now we're in that part of the continuum of care of thinking about what's next and what's the best thing for people to do in the next phase after they've had the cancer and it's been treated. It's a huge monumental task, I think, for every patient that goes through it. And you would know that better than me.
I love having these conversations because it really puts such a retrospect and an audit
Mm-hmm.
on what has happened beneath the mask. It's so easy to get caught up in the fact that, yes, we're here in 2020, 2021, and this happened so long
Right.
ago, it's hard to even imagine what it was like, but we were there at that time. When did you start to see real response from the consumer space, from the American citizens on the cancer prevention, the non-smoking stuff? Like, when did the eat better, exercise more, and do your best to try and not get it conversation start up?
Well, I'd say it's probably about this, we've known forever about cigarettes, right? But the science on the lifestyle factors that cause cancer or lead to a higher risk of cancer really has been in the last 20, 25 years. It's one of those things where we're, working as hard as we can to sort of explain the connection. And for whatever reason, it seems with the studies that we've done, something that we're working on right now, is that the connection between these behaviors and cancer it just hasn't hooked up in people's minds that these things are modifiable. So you would do exercise or be physically active to prevent, becoming overweight, high blood pressure, diabetes. But no, people don't connect those behaviors and doing more of them with preventing cancer. So that really is the push right now, is to sort of get those healthy behaviors hooked up to this could prevent cancer and could prevent another cancer from happening again if you've had one previously. So that really is the thing we're doubling down on here at CDC, is working on our communications and trying to do better with that.
One of the things that the CDC does that most people would probably not know you do is workforce empowerment and making sure that talk about that too. That's really important.
Yeah, so just to educate providers as well as educate patients, to train more epidemiologist type, health services researcher types, and just to get out on the ground and do the work with the people and train, in public health, how to implement these interventions in communities as well. So that's really the main place that we're working in right now.
So let's go into this. You can debate this anyway, which way to Sunday, but screenings have changed dramatically. This year it's this age, this year it's that age, this year it's covered, this year it's not. From your global perspective, having been there such a long time, is there any sort of consensus on, we're all trying to do this to help people not get sick, but wherein lies the rub in coming up with something cohesive and conclusive?
So the biggest challenge with the cancer screening recommendations is that you probably just stated it another way, is that there's so many of them and they're not all consensus, going in the same direction necessarily. But what I would say is that there are places that we agree on screening, which is what's the age to start. There's been a lot of controversy in that in breast and colon rectal cancer recently. But we would say, your middle age, 45 to 50 years old, the intervals 1 to 2 years, colon cancer 10 years. But it really is an evolving science. And that's the other thing. Like with the pandemic, when people get upset about, the changing recommendations, it's the same with screening. The more we learn, they're going to change, and people just have to feel comfortable with that.
Yeah, not easy.
Not easy at all. Yeah.
All right. So another question I have kind of goes back to, you've done a lot of work with a lot of advocate groups on this magic word like carcinogens in our food, right? Food safety. It's one thing to talk about, well, eat better and avoid this, and donuts don't make good on your hamburgers. Yes. It's another thing to try to unpack how industry gets all these multi-syllable things in things you eat, and there's no regulations or no one's calling them out.
Right. So in that area, that's not what we specifically do here at CDC. So I would say, to your point, as few preservatives in your food as possible. If you can get it fresh, canned foods are very good as well. It's fresh out of the field. But to just, I don't know, I guess people call it, what do they call it now? Eating clean. But, to eat fresh fruits and vegetables if you can. If not, eat this, less meat. That's a hard one for all of us, right? But just to eat a balanced diet, and you don't need vitamins if you do that. And so, but that's the hard sell because people want to eat what they want to eat and drink what they want to drink.
So let's move on to talk about what specific role the CDC plays in terms of standards and best practices and how you work with groups like, let's say, the National Comprehensive Cancer Network or the Academy of Cancer Research, the ACS. We're looking to make sure that when patients enter that store that they never wanted to shop in,
right,
they are aware of what their choices are. And there's no like Abe Simpson Walmart greeter to tell them what to do.
No.
Talk to us about how like the experience of the patients matters through this lens of what the CDC tries to influence.
So I think from my point of view, as the director of the Division of Cancer Prevention and Control, is really to provide information in a format that is digestible and understandable by the patient. So one of the things we've been pushing towards in our communications are working with, for instance, one thing we've developed in the last 2 or 3 years are simulated humans that patients can interact with. One is for triple negative breast cancer treatment, one is for prostate cancer treatment, but to provide tools that are more, today type style other than paper, and to really just help patients walk through the experience and know what to expect. Because, unless you've had cancer, it's just, you just can't even imagine what it's going to be like.
Back with our guest after the break.
Has your chronic illness made it difficult to continue working in the traditional way? Want to learn how to find and create flexible remote work that both accommodates your chronic illness and generates an income? Join the Patients Getting Paid membership, a community of chronicpreneurs where people just like you find workshops and trainings, weekly updated condition-specific gigs, twice monthly coaching calls, co-workings, accountability, and the kindest community to support you on your path to make money while working from anywhere and taking good care of yourself. Learn more or join us at patientsgettingpaid.com.
So picking up where we left off, we can't not talk about the massive elephant in the room. As of this recording, it's, mid-January in 2021. There's COVID.
Yep.
It's a thing. It's horrible. There's nothing good to talk. There's no Hallmark card to buy on the shelf that makes it any better for anyone
Right.
in the world. The CDC has played a prominent role. Clearly, even prior to this, like with Ebola and SARS, like it's institutional to help people get through this.
Right.
But specifically through this lens of cancer, it's wrecked screenings. It's wrecked compliance. What have been your main observations on the early data coming in from what it's done so far?
So the main observation from May through March, through the summer is that cancer screenings plummeted to just about zero. As they were coming up in September, I think the last data I saw published, they were about 20% lower than they were in January when this whole thing started. So it came back up. But this was when the pandemic was waning a little bit. So now we're in, it's going up exponentially again. And so I anticipate the screenings are falling off again, not necessarily back to where they were, because providers have put things in place to keep patients safe and patients may feel more comfortable. But people are really terrified about going out and getting anything done. And it's just trying to get the messages out there. Call your doctor, see what's going on in your community, see what they're doing to keep patients safe, but not to neglect your health care.
Right. The fallout from this probably won't be seen for months and months and years to come.
Probably years. We anticipate the models from the National Cancer Institute looks like it may, within 2 to 3 years, we would start seeing. Actually, from last year, 2020, when those data become available, there may actually even be an increase in cancer mortality because people are afraid to go out and get treated or get screened or all the things that you said before. So we'll see how the numbers fall out, but I would anticipate that the number of cancer deaths may even go up in 2020 even.
I would be really curious to find out longitudinally the role that telehealth played in any oncology conversations as an intermediary solution.
Yeah, I think the substituting out in oncology with telehealth was not as great as, let's say, primary care because you need to come in to get your chemotherapy. But some of the data that I saw at the beginning showed that if you were in treatment, your treatment continued. The real challenge was surgeries stopped. And if cancers don't get diagnosed, the chemo doesn't happen and all the, array of care would occur. And so that's really, I think, where the challenges are. Moving forward, the prediction is that there'll be higher stage cancers, which are harder to treat, which will lead to more people dying from cancer. So we're really trying to double down on those messages about getting out and getting your care, making sure it's safe, obviously. But the pandemic, we don't feel like it's ever going to end right now, but I believe it will end, and we don't want to be so far behind the 8 ball that we can't catch up.
Right. And for what it's worth, as of this taping today, my wife just got vaccinated, and my parents, who are in their early 70s and vulnerable, are getting vaccinated this coming Sunday. So hopefully that's one nice thing to see today, at least as I'm talking to you.
Exactly.
So another question I have is there any data, dashboard, something American citizen friendly to look at about how the virus may have affected people who have been in inactive treatment, or is there no way to yet know that kind of like a demographic segmentation?
So the only place I've seen data, Matt, is in the people that use claims data or the people that pay claims. They have looked at the volume of services, and what you see is what you just said. Everything kind of fell off. And the information I was sharing earlier came from some of those vendors analyzing their data about the volume of people coming through. Chemotherapy dropped, radiation therapy dropped, surgeries dropped. And so hopefully these things won't take too long to come back up. But again, we're having a COVID surge. And so lots of hospitals have again shut down surgeries that aren't, urgent or emergent. But I think what I've read is that hospitals are trying to preserve the oncology surgeries that need to be done because those are more urgent than, let's say a knee replacement, right? So I think there's some juggling going on out there in the healthcare system, trying to figure out who to treat now and who can wait.
Right. Other data that I'm just curious to see met out at some point is, we initially talked about the vulnerable population with weaker immune systems,
right.
The elderly. That included some rare disease communities, and that included people either in active treatment that were metastatic living with cancer, right, or only recently perhaps off treatment. Is there a narrative on that too?
So the narrative there is the best that we can tell is that, if you are actively being treated for cancer, your risk of getting COVID may be higher, and you may have a higher risk of having severe complications like being hospitalized. But, depending on which type of treatment you're looking at, there are different outcomes. Some seem to be, lead to worse outcomes like surgery if you're like older, have metastatic cancer, the thing you mentioned before. So there is a little bit of information out there, but I think it's still so new. It's just really hard to tell. There are several groups out there like the COVID consortium, cancer consortium that are, tracking people hopefully prospectively, and we'll know something sooner than later. They published one paper, but I haven't seen anything else from that group.
Yeah, I was really surprised, and maybe not surprised, I'm going to be harsh, that, by April or May, there really wasn't like a one stop shop for scared cancer patients in the communities to turn to for layperson
Right.
advice and guidance because everything was just so chaotic. So
Right.
it's still out there. I still get questions all the time from listeners, from just friends and colleagues and executives and whatnot. What do cancer patients do during the pandemic? And this is a true or false round, right?
Yes.
The inclusion criteria for the vaccines may or may not include if you've had radiation, you can't get it. True or false?
False.
Good, because I've been asked that question.
You should be able to get the vaccine if you've had radiation therapy. Yes.
So also active treatment, living with certain medications. Are there contraindications on what pills you're currently taking for your regimen that are not in the interest of getting vaccinated?
So the biggest contraindication, just knowing how cancer works and how treatments work, the biggest contraindication are people who are immunocompromised by their medications, or if they have a cancer that immunocompromised, like a lymph node cancer, like lymphoma and leukemia. Those obviously that's where the immune system resides, and so those people are definitely at higher risk. Now, the deal with that is still, to get like we recommend the flu vaccine, you'll get the vaccine. You may not have as strong of a response, but I think it would, protect you from getting as sick, similar to what we recommend for the flu vaccine as well. And this virus, this vaccine is safe because it's not a live virus. Cancer patients should not be getting live virus vaccines.
Right. And let's do a one-on-one here. Like, what is mRNA? Because this is not smallpox stuff.
No. So this is actually kind of interesting. It's the first messenger RNA virus that we've developed a vaccine for. That the vaccine is actually the messenger RNA. Sorry, pardon me for that. So it's the first one. That's why it has to stay so cold. But this is actually the RNA is what the proteins are made from in the body. But I think it's safe. It's not a live virus. It doesn't cause disease. And so people should feel comfortable getting it. Should.
Right. Magic operative word is should.
Yes. Should. Yes.
Yeah. On the next 11 shows we do masks work? Totally kidding. We can avoid that conversation just for today.
Yes, masks do work.
Yes, we know that. I mean, we could lurch into any sort of conversation at this point, but let's keep on track here. I just have a few more questions in the no stupid questions portion of this entire episode. That is every question I ask you. This goes back to the vaccinations and access to vaccinations and rollout of vaccinations. And if you're vaccinated, is there a CDC recommendation on should you still wear a mask a month later? Should you not? Will you be judged by society if you don't have to need one, but you have to tattoo your I got vaccinated card on your chest or something? Where are we at with that?
So the what you're asking, so the root of the question is if you've had a vaccine, can you no longer transmit the virus to someone else? It kind of sounds kind of weird, but you can still get the virus, but it doesn't make you sick, but you can still transmit it to someone else. So that's the working hypothesis right now. Like I said, a lot of more research to be done. So yes, you still would have to wear a mask until we reach that magic number of population vaccinated, which people are saying is somewhere between 70 and 90% of people being vaccinated.
And that's not including children, right? They're exempt from this for now?
No, I can't remember what the lower age is, but children, I can't remember the starting age for the vaccine. My apologies.
So masks on for the foreseeable future, despite national vaccinations.
Right. But I mean, you'd have to vaccinate enough of the population for that thing that confuses everybody, something called herd immunity.
Yes.
So you would have to have 70 to 80% of all Americans vaccinated to actually have herd immunity.
I see.
We got a ways to go
All right,
with the current numbers, but we just started. Right.
All right. So final question on behalf of my inner rip whatever hair is left in my head, out of my head, parents, school, kids, COVID, is it feasible to hypothesize that possibly by the end of next summer, schools will reopen nationwide full time?
I tell you, I can't name that. Every time somebody asks me that, I keep putting the date off when we're going to get out of COVID, what I call it, COVID COVID cabin fever.
Yeah.
But yeah, exactly. That's what I have. But now I hope by the end of the summer that we'll up to a level of vaccination that's, we can put kids back in school. It's a plus minus and everybody does their own way. So we'll see, but I hope so. I can't say for sure.
Well, this has been like Password with Chuck Woolery version of questions and answers, and I can't thank you enough for this. And I will definitely have you back, as I'm a ceaseless engine of dumb questions that aren't dumb questions, and they keep piling up. So I'm happy to receive your wisdom. And
there are no dumb questions, by the way.
Yeah, I'm just trying to be Woody Allen here, so go with it.
You don't look like Woody.
No, I don't. Anyway.
Just joking with you. Anyway, but no, it's been a pleasure.
Yes.
Always like talking to you.
Likewise. Dr. Lisa Richardson, Division Director, Cancer Prevention and Control at the Centers for Disease Control and Prevention, the CDC. Thank you so much.
Thank you, Matt.
That's all for today, folks. If you like the show, be sure to subscribe, leave a review, follow us on social, and tell all your friends to listen. Out of Patience with Matthew Zachary is a product of Offscript Media. Our executive producer is Matthew Zachary. Our senior producers are Jen Horangeff and Andrew McDowell. Darren Tunn is our production intern. It is recorded, mixed, and edited by Matthew Zachary. Our theme music is by the Mike Van Allen Quintet and by Mara. For advertising and media inquiries, email media@offscript.com. Hit us up at contact@offscript.com to share comments, feedback, and make guest recommendations. For more information, visit offscript.com.